Just get confirmation that's yeah.
That's great. Thank you very much.
Okay. Yes, it's always a worry talk on technology that the technology works appropriately. So I'm Professor Pratik Chowdhury. I am at the University of Leicester. I came up after 15 years at King's College London. And tonight I'm just going to share a little bit of the work I've been doing and how the face of diabetes management has really changed in the 20 or so years that I've been a practicing clinician in diabetes, and maybe a little bit about the work I've done. So these are my disclosures at the start. I've worked with a number of different companies and I've had research support from manufacturers of medical devices. And of course, just want to highlight today's World Diabetes Day, where we just acknowledge and reflect on the progress that's been made in this field over the years. So just to set the scene, in the UK, there are over between 3 and 4 million people living with diabetes in the UK at the moment, probably another 1 million or 2 with pre-diabetes. And of course, there are 2 major types, type 1 and type 2, where type 1 diabetes comes where there's autoimmune destruction of the pancreas, the body doesn't make enough insulin. It's between 5 to 7% of all diagnosed diabetes, more common in those aged under 40, but a common myth is it's from birth. More than half of type 1 diabetes is diagnosed over the age of 18, and maybe a third over the age of 30. But these people living with type 1 diabetes must take insulin. Actually, a large proportion of my work has been focused on people living with type 1 diabetes. On the right-hand side of that little cartoon there, you can see type 2 diabetes, where there is insulin production, but because of insulin resistance, most commonly related to obesity, the requirement is higher than what you can make, and that's about 90 to 95% of all diagnosed diabetes. More common as people get older, but as you all know, there's an increasing epidemic of young onset type 2 diabetes. And actually, as it stands now, there are probably more new cases of type 2 diabetes in those under 40 than there are type 1. And of course, there's a combination of diet, exercise, and medication, but ultimately, many people with type 2 diabetes often end up needing insulin. And again, there are more people with type 2 diabetes using insulin than there are people with type 1 diabetes. Now, around insulin, managing glucose levels is very challenging. It's a drug with what we call a narrow therapeutic index, which means that you've got very little margin to get the dose right. And in particular, a lot of people are afraid of getting low readings, and that often is a major challenge to people achieving glucose levels that can prevent complications. Now, diabetes management of those complications are a huge burden on the NHS. As you can see, they're about 1 in 10 pounds, almost 9 billion pounds a year are spent on diabetes. And of that, more than 80% is spent on the complications of diabetes that occur because we haven't invested enough upfront in the right medications and technology: amputations, blindness, kidney failure, stroke, and cardiovascular disease. And this was an infographic from Public Health England about 1 in 6 people in hospital have diabetes. And actually, I think that's slightly out of date because the latest inpatient diabetes audit suggests that for most hospitals now, certainly in areas like Leicester, this is 1 in 4 of all people in hospital currently have diabetes. So a large focus of the work I do and about technologies is how do we support people in this balancing act? And you've got that meter in the middle there with a low glucose, a kind of middle glucose that you want to stay in, and then the high glucose. And on the left there, I've got some things that people might be scared of. When glucose goes low, you might lose your balance, you might get incoordinated, you might have falls, which is in the elderly. You can have seizures, and in very serious cases, unconsciousness. And of course, one of the worries of people on the road driving is around having accidents, losing that coordination, losing your reaction times. And I'll come back to why I've got driving in there in a minute. On the right-hand side, I've got the common complications there. You've got heart attacks, strokes, and amputations that take up a lot of the money spent. And actually, the person in the middle has to balance this juggling act. You've got the acute risk, the short-term risk of my sugar going low, me becoming incapacitated, me embarrassing myself in front of colleagues, or having a crash or seizure or fall, versus something that might happen 20 years down the line in the future. And inevitably, people err on the side of running high, which is why we have such a high cost. Now, when I started doing diabetes about 25 years ago, and I put this guy in the blindfold in the middle because it was a bit like you had a blindfold on and you can measure your glucose by doing a finger prick, see where you are. You had to take a dose, take an action, then you had to walk down this tightrope between hypoglycemia, low glucose, and high glucose until you got to your next stop where you can open up the next meal, have a look and see, did you get there safely? And that's the thing that's really changed with a technological revolution in diabetes that I'll talk about. And again, I use this because I was at a meeting where a parent of a young child with diabetes made the comment that, when we get diagnosed, we have to prick our child's finger multiple times. We then get these pens and we have to inject our child, stab our child with these pens multiple times a day to get the dose right to prevent complications. But if we get it wrong, there's this glucagon pen that can bring them back, if they go too low, from the dead, as it were, to life. And it's a very kind of emotional way that this balancing act landed on this father of this young child with diabetes. So the ideal glucose is somewhere like this. It's as close to the edge of hypoglycemia as you can get without falling off. And in a way, I've found this picture online and I've used it in a lot of talks to both people living with diabetes as well as professionals, saying that the reason why this guy gets this close to the edge is because he's got skills, he's got practice, he may have the right equipment, there might be a safety net underneath. So there's lots of things that go into the confidence to get close to the edge without falling off. Now, you or I might look at that ledge and say, we're not going anywhere close. And we take the natural decision to stay a few steps back. And that, how can we encourage people, give them the right tools, the skills, the practice, the confidence to get close to that edge safely without falling off? So the reason I got into diabetes and the first kind of use of technology was around driving, because the advice for people living with diabetes, if they're driving and they feel that they're low, is to pull over safely, switch off the engine, take some carbohydrate, and then they can't drive again for 45 minutes after the glucose has gone back to normal. The risks are higher. And actually, when I started, if you were a lorry driver or a bus driver and you required insulin, you would lose your license, because the fear was that you might end up as this guy has, where the truck driver suffered a diabetic episode, a low blood glucose, and he was trying to get to a rest stop and ended up driving to this rest stop and having an accident in which a girl lost her life. And so because of fear of that, a lot of people who are doing professional driving or who are going to drive run really high. And at the time, sugar's running high. The right treatment would move this person onto insulin if they had type 2 diabetes, but they wouldn't, because they'd lose their job. And so I started in this in a Department of Transport funded study looking at the rates of hypoglycemia. And we did this study, and we used this a very early technology. This is 25 years ago, the first commercial continuous glucose monitor. And what we did was we recruited 450 people over 6 sites. And we asked them about hypos every week for a year. And then we used this continuous glucose monitoring technology to find out, are they having any lows that they didn't actually know about? And using that, we were able to find, if you look at the graph there, the first line there is about a 7% rate of severe hypoglycemia, that is episodes needing third-party help, in people on tablets, sulfonylureas. And actually, if you look at people with short duration of insulin treatment, less than 2 years, there is no difference. But once they're on insulin for more than 5 or 7 years, we can see that rate of severe hypoglycemia starts to rise. And in people with type 1 diabetes here on the left there, it's even higher. But on the back of this research and a few other pieces of work done around Europe, and this was my PhD about 25 years ago, there was a change in EU law. Because the risk of hypoglycemia wasn't that different, it allowed insulin-treated people to drive Group 2 vehicles, that is vehicles over 7.5 tons or over 15 passengers. And that now applies to lorry and bus drivers, taxi ambulance drivers, paramedics. And actually, as a result of that, now ultimately, I'm now on the medical advisory panel for the Secretary of State. And we've argued to allow technology like this continuous glucose monitoring to be used to assess people to see if they're safe to drive. So if you talk about the technological revolution in diabetes, ultimately, there are 3 steps to managing diabetes at any given moment. You need to know what your glucose is. You then need to make a decision. Do we need to bring it down, bring it up, or keep it steady? And then if it's up, we need to deliver some insulin. And of course, when people started, and I've come across many people who used to dip their urine to do a chemical reaction to see what the glucose was. And of course, that would tell you what your glucose was since you last passed urine over the last 5 to 6 hours. You then make a decision and you take insulin, usually with syringes. We then moved in the 80s to finger prick meters, people recording data in diaries, and insulin pens, making that insulin process a bit better. And now, over the last 10 years, we're in a kind of advanced phase where we've got technology like continuous glucose monitors that measure glucose all the time, every single minute. They can alarm and alert to tell if sugar's too high or too low, and they send the data to the cloud. They can also send the data to a loved one. So for parents of children with type 1 diabetes who maybe have been not allowed to go to that camp to their friend's house, they can go there and their data is shared via the phone with the parent to see what's happening. And we're delivering insulin in smarter ways as well. Instead of someone having to take an injection multiple times a day, we're doing work with pumps. And of course, once you've got a glucose reading and an insulin pump to deliver insulin, you can match them with a control algorithm to try and automate some of those processes. And I've been involved in studies that have tested all of those things over time. So the first step was better glucose monitoring. And you'll have seen many people out on the streets here with these little white discs at the moment. And these are Freestyle Libre glucose monitors that are now widely available on the NHS for people with type 1 and increasingly with type 2 diabetes. On the bottom there is a Dexcom system, which does pretty much the same thing, but from a different manufacturer. On the top right there in the middle there, but with these sensors, of course, you have to change them every week, and we lose data because if people are on holiday, they forget to take them with them. The sensor is external, people don't want to wear them. And so we have gaps in data where people might not have access to their data. So that middle device there on the top there with a little fuse type device is an implantable sensor. So again, we tested this device and got it to market where you'd make a small nick, implant the sensor under the arm, and it could read the data out to a mobile phone, and that could stay in the body for up to 6 months. And at the bottom, there's just a picture of some new devices that might be coming to the market, which are more durable, that can be embedded in consumer devices like watches. And for all of these systems, studies that we've done, we have to be sure that they've had the right accuracy testing. Are they actually reading what blood glucose says? Because these systems aren't actually reading glucose in the blood, they read glucose in the skin, and there's a slight difference. We have to test their accuracy. We then have to do clinical trials to show if they work, and then evaluate the accuracy and benefits in the real world, and then support NHS implementation. And just that process with the Freestyle Libre, I was involved in pulling together the ABCD. This is the Association of British Clinical Diabetologists. And once the sensors started getting rolled out, we recruited people into a national audit and got anonymized data from over 6,000 people. And we demonstrated that when people are using these systems, there is a reduction in glucose levels, about a 0.5% reduction in HbA1c, which is a marker of your long-term risk of complications. There were significant reductions in hypoglycemia. If you look at the graph there, the blue bar of severe hypoglycemia, just over 1,000 people had had an episode of severe hypoglycemia the year prior to using these systems. And a year down the line, that was down to just over 200 people. So we don't take away the risk of hypoglycemia completely, but there's significant reductions there, as you can say, in admissions for high glucose, that's DK, for low glucose, that's hypos, for paramedic call-outs, and for severe hypoglycemia that people manage at home. This was also associated with significant improvements in quality of life and reduction in admissions. And on the back of these data, again, that helped the rollout. We also were able to look at these data, and because they connect to the cloud, I was able to look at things, and we were able to see what was the impact of COVID and the lockdown on data. And as you can see here on the right, in those 4 different age groups, as soon as lockdown happened in early March, all the numbers for glucose control improved as people stopped going out, eating out, and had slightly more regular lifestyles. So we saw, but it also gives a feel for where the UK is. This was 10,000 users, and we can see that about 10% of people were achieving target glucose, 20% getting it to a kind of slightly looser target. And that means that almost 60 to 70% of people are still running high. So despite having access to this technology, they're not quite at the level that avoids complications. Those data were really important. In 2019, when we started looking at regional maps, what the map on the left shows is in green are the areas of the country where Freestyle Libre, the CGM, was freely available and where more than 20% of people were using the system. And in red were places where people weren't using it. And using technology, using social media, using the right data collection, we were able to lobby, secure funding, turn those red areas green. And as you can see in 2023 now, this continuous glucose monitoring is available to every single person living with type 1 diabetes, irrespective of where they live in the UK. With this widespread rollout of technology, though, it's really important that people living with diabetes, but also the healthcare professionals, are skilled and knowledgeable at how to use it. And so I chaired a group called Diabetes Technology Network, and we built a whole bunch of educational resources for healthcare professionals, but also for people living with diabetes. And what we did was we kind of wrote the same content for both sides. And the idea was that if people living with diabetes watch those videos, and actually anyone can Google DTN UK and educational resources for people living with diabetes and gain access to educational material about how to use these technologies, how to navigate the path when there are so many choices of technology. We also then broke those same videos up into micro learning with assessments before and after, and put that behind a kind of regulated platform called Academy, where you need a GMC number or a nursing number to sign up. So people could get CPD approved education reading the same thing. And then we've got a showroom, we've got expert use on devices, and we've written some best practice guides to help healthcare professionals upskill with this rapid improvement in technology turnout. And at the top there, I've got two of my colleagues who work with me in developing this platform. Yeah, and over the course, we've got lots of videos. As you say, we've got about 27 hours of training material now. Since the slide was, I think, more than 2,000 clinicians have been onboarded and watched loads of content and got their CPD certification. We also, as this was happening during COVID, realized that this old-fashioned method of kind of getting people into hospital and then teaching them how to use technology wasn't appropriate, and we could work differently. So Hannah was working with me. We created, well, how can we use technology to make technology work better? And so we got virtual showrooms, and we got online training pathways and SOPs written for teams to use. And actually, as a result of this, we've just published the data showing that people who were started on this technology face-to-face had the same outcome as those started virtually, where we just posted kit out to people and showed them the videos and said, start the technology on your own. And this is really using technology to help technology. So as I said, the standard of care today is someone with diabetes, someone has a sensor that reads a trace, and you can see here a trace that goes from midnight to midnight. The gray zone is the target zone. And in the middle there, you can see that red reading of 3.2, which is when the patient has taken a bit too much insulin and dipped down below that 4 mark. The rise is when the person eats food, and the drops are when they take insulin. And that person has had to take 4 or 5 injections a day. But of course, as I said, another way of getting the insulin delivered is a pump. And so some people measure their glucose multiple times with finger prick or sensors, and then use a pump like you see in the picture above to deliver insulin whenever they feel the need for it. And of course, a big part of that is the decision making on how much insulin to take. And so we've done a lot of work with companies to develop apps and to use the apps that do that decision making for them, because actually it's quite a lot of maths involved with living with diabetes. You've got a carbohydrate content. So for every 10 grams, you're going to take 1 unit. So if you're having 40 grams worth of food, you need to take 4 units. But then if your sugars are high, you need to add some extra to bring it down. And there's lots of factors. And the reality of the matter is, although we teach people these complex calculations, what we know is less than half of people have the mathematical skills to do those calculations. And of those, how many are going to do it every time they put food in their mouth? And so devolving some of those robotic mathematical calculations to apps has resulted in real benefits in glucose control. Now, the real exciting thing is closed loop systems. And this has been something that I've been involved in from very early studies, where we bring people into our clinical research facility, and the algorithm would control their glucose, but we'd sit there watching to make sure it didn't do anything silly and stupid. And we'd have to sit there overnight watching the machine and getting alerts if the glucose went high or low. The nuts and bolts of this are, you've got a continuous glucose monitor that measures glucose. And I think of this as the speedometer. And then you've got the insulin pump. Think of this as the accelerator. So as maybe your speed goes up, the pump will back off, give less insulin if your sugar's going too low, rather back off and give less insulin. If the sugar's going high, give more insulin to try and bring it back on level keel. And doing that is your control algorithm. Ideally, maybe the way I explain it to people is a bit like the maths in there, the same maths as in your cruise control on your car, trying to get you to steady number. And this is just a picture for those who want to see about how it does it. So you've got the glucose line there. If you look on the left there, that kind of full line there going up and down. If you look at the bottom, those little green bars are going up and down as the system decides every 5 minutes how much to give or take away insulin. You can see a gap there in the evening where it stopped because the glucose is going low, and as the person eats, it goes up. On the right, there another example from a different system showing the same sort of thing. So at the moment, these systems can keep your glucose relatively steady. You can see there from the line, it's not absolutely flat line because people are moving, eating, acting, being stressed, being relaxed through the day. So there's always that kind of rise and fall, but we can keep it in that green zone. And I was involved in some of those very early studies where we got people into the lab, into our clinic and watched them overnight. But then the very earliest studies showing their benefit. And this is a study we did here in Leicester. We led from Leicester, and we took people whose sugar control was a little bit high at 9%, and we're aiming for a target of about 7%. And we randomized them to stay on the sensor alone at 9%. We put them on the closed loop system, and by 3 months, you can see they've dropped down almost to target 7.3, and then out to 6 months, they've stayed at that 7.3%. So that's a 1.5% drop, which is actually huge, and it's life-changing for a lot of these patients. On the back of some of these randomized controlled trials, the NHS then said that they would fund a pilot of 1,000 people to see how it worked in the real world. Because of course, in a clinical trial, we're very closely monitoring these people. They're being seen at very fixed intervals. So I was involved in, again, leading and analyzing the data for this hybrid closed loop pilot. And across the country in 30 sites, we recruited 600 patients who were brought into this pilot. They had to be on an insulin pump already with the CGM, but have a high HbA1c of 8.5%. And on those 31 centers, we recruited 520 people. And over 6 months, we looked at the outcomes, and you can see there that there was a 1.7% reduction in HbA1c, which again is huge. We got people up to about 70% time in range. We got a lot of people with reduced diabetes distress, which marks an improvement in quality of life. And now on the back of that, there's been a change to NICE guidance. And actually just last week, there's a new guidance published giving people access to these closed loop therapies. So anybody who's planning pregnancy, has got problems with hypoglycemia, or has got high HbA1c can gain access to this. And so we'll be really now focusing on how we implement this across the NHS. And so that's a great story of taking research from the lab, from the clinic, into a clinical randomized controlled trial, into real world evidence collection. And now we're at the phase where we're implementing this as standard of care. So I'm going to swap track now for the last few minutes of the talk and say that actually alongside this technological revolution, a big interest of mine has been impaired awareness of hypoglycemia. So, I talked at the start about how the major barrier to diabetes control is this fear of going low. And on the left there, you've got common symptoms people might have if the sugar goes low: sweating, palpitations, trembling, weakness, drowsiness, or extreme cases, seizures. And most people with type 1 diabetes will experience 2 or 3 episodes of symptoms of hypos a week. And we know that repeated episodes, if you're having more than that, you get at risk of your body stopping reacting and giving you those symptoms of hypoglycemia, leading to impaired awareness, which is where people don't recognize that they're going low. And that puts them at increased risk of severe hypoglycemia, where they'll need someone else to help them out. So the first step that I was involved in, and I work with a couple of my PhD students there, is looking at education. If we teach people how to use insulin properly, in the UK, we have a course called Daphne, you can reduce the risk of hypoglycemia by about 50%. But these courses require about 20 or 30 hours of education delivered over 1 to 5 weeks, teach lots of different aspects of it. But what we realize is that whilst there's a huge benefit from doing these courses, not everyone can attend. Technology again, and so again, 2 of my students did a project, and when I was working at King's, looked at the outcomes for severe hypoglycemia using insulin pump therapy. And with a pump, you put in more information, but also you can adjust the insulin far more precisely. And if you look there, the proportion of people, so people were having, with hypoglycemia, having 2.9 episodes a year of severe events needing third-party assistance, dropping down by more than 75% to 0.6 episodes a year once they went onto pumps. And then we were able to connect those pumps with CGM, and the first generation of systems, and this was one of the first papers published with that from a clinical use of these systems, was systems where if the sugar went low, it would turn off the insulin delivery. So if you went high at this stage, the kind of governance didn't allow us to deliver insulin, but we could take insulin away if it was no longer needed. And you can see here, the people we were then able to put on working when I was at King's had an average of about 5 episodes of severe hypoglycemia a year at baseline. And then as we put them on these systems, we can see that their median became 0. And the proportion of people having severe hypoglycemia significantly reduced. Same data there. And then we went to the next stage of that technology. So the next evolution of that technology was something that would turn the insulin off if it thought hypo was going to happen. So the first study was it would only turn off the insulin if you were already low, but this system would turn off the insulin if it thought that you were going to go low. And what we found was that the time spent in hypoglycemia there went from 4.2% down to 0.9%, and the rate of severe hypoglycemia dropped by 87%. So, and this was a study done in high-risk patients at high risk of severe hypoglycemia. So you can see there, 52 per 100 patient years, so about half of patients in the study had a severe hypo in the control arm using standard of care. But when we gave this system, you can see a dramatic reduction in the rates of severe hypoglycemia. And again, it's this study, but others like it, that helped NICE guidance change and say, if you've got a severe hypo, you need to have a pump and a sensor with this technology that reduces hypoglycemia. But I'm also aware that technology isn't always the answer. And this has been really clear to me from the start. So this was just a patient who I saw a number of years ago now with recurrent severe hypo. She'd had 5 hospital admissions for hypoglycemia in the last 4 months. And I don't know if you can see there, the kind of gray zone is a glucose of 4 to 10, the target zone. And this person is doing a lot of readings. A lot of those dots are happening below 4 in the hypoglycemia range. So working there, we did standard of care, intensive support. We got on continuous glucose monitoring that alarmed when it went down. And I hope you can see here that actually we have a lot more of her data in the gray zone, and we've minimized that time below 4 significantly. So we'd worked really hard with her, got things going, and I was seeing her every couple of weeks for 3 months. And then she went away for a bit, and we let the next appointment for 3 months. And when she came back, I hope you can notice here that what was happening, there's no data in the overnight period. And that's because she was going low overnight and was beeping, and so she turned it off. And in the day, you can see way more red again. And this speaks to the fact that a long-term condition like diabetes has a big play of your psychology about how you think. And so it's cases like this that led us to think, what is happening to these people? And also, why is she not able to recognize herself when she's low and is reliant on a machine to tell her she's low? What's different? What happens? So actually, one of the key things we did was, with a couple of my PhD students there, we'd make people, take people into the MRI scanner and make their glucose go low. And we were comparing people without diabetes with people who could feel their symptoms and people who couldn't, to try and see if we can work out what was different. Why are these people not responding to low glucose? And then we tried to restore hypoglycemia awareness, reduce their risk of hypoglycemia using technology or education, and we had a look at what changed in the brain. And these are the sort of things that we see. So again, this is a different type of technology in diabetes, where we're using technology to research what's going on. And broadly speaking, what you're seeing there are the red blobs are parts of the brain that are being turned on when glucose goes low. And the green or blue blobs are areas where the blood is being diverted away from. And those green and blue blobs are areas involved in speech, language, decision-making, memory, balance. And the red blobs are areas involved in stress and decision-making. And what we learn is that if people who are hypo-aware, the brain areas that get activated suggest that hypoglycemia is being perceived as stressful, unpleasant, unrewarding. And they have an emotional memory of this response. So that's the internal motivation to avoid future episodes. Whereas those without hypo-awareness, who don't feel the hypos, we actually find some areas of the brain that find some of this actually pleasant. But because they have no emotional memory of what's happening, they don't feel unwell in any way. Often the advice to make changes isn't heeded because there's no internal motivation to change. Recognizing that, we developed an psychoeducational program called HeartDoc and piloted it in a randomized controlled trial, where we identified certain thinking traps, certain thought processes, and we used motivational interviewing and CBT in a group setting to address those thoughts, acting early, preventing those lows. And this RCT that we performed in over 100 participants showed significant reduction in severe hypos and improvements in mood. And finally, if we go on, so there's lots of apps out there, and there's apps that can help with, and this is a wheel that came from actually Leicester of the different areas that should be targeted in type 2 diabetes. And actually technology can help with each area. We want to do weight management, and so what you can't measure, you can't change. So tracking activity, tracking diet, tracking motivation and support. Delivering insulin for the right medications for insulin along with drugs using technologies. Making better decisions about what to do and remote monitoring, and cheaper, faster screening and identification of diabetes, and using data and artificial intelligence models to maybe personalize our approach to individuals about their individual risk of high and low. And tech is helping in all of those different aspects, and we're getting involved in studies, in partners, in companies, in collaborations that are working in these different fields. And finally, what technology is doing is driving a lot of data. People are recording their activity, recording their glucose readings, recording what they eat, and how can we collate these for better control? We are now interacting with our patients differently. We're doing clinics remotely. People don't having to take the day off to come to hospital. And because there's data collected, we can now review patient dashboards. We can find out who is struggling the most, look at their data, and then proactively engage with them through virtual consultation, and bring people in who might not be, and people who are doing really well, maybe not disturb them, let them carry on with life and say, you're green on all your parameters, we don't need to see you, and being more efficient with those limited resources of doctors and nurses that we have. And this is a real big move for technology that we're moving. And finally, just to mention, again, with technology, with all this data collection, I'm involved in a large European project called the READY. We're working with regulators to see how can we use this data for better decision making. How can we match data and evidence from randomized controlled trials there in the red, and see, well, in the randomized trial, if a technology or a therapy or a drug has a certain benefit, can we use national registers? And we've got the Swedish, Danish, German, and British national registers involved in this project, and see, well, if it does this in the randomized trial, what does it really do in the real world? But then maybe look at virtual trials saying, well, actually in your main trial, you excluded people with comorbidities. You didn't have enough people from ethnic minorities, but we have those people in the real world data, and let's see how things match up. So again, using data, using technology, we're able to expand the way in which we use information that's gathered. So ultimately, I think the next few years will be about how we fit things together, how we measure glucose, how we get electronic prescribing, how we integrate consumer electronics like wearables and activity monitors, make appointments that are more patient-initiated, link in imaging and national data sets and patient-reported outcomes, and put it all together to get a better picture of what's going on and deliver better care for our patients. So I think ultimately, we're just at the start of this technological revolution. Current technologies like continuous monitors, pumps, and closed loops are relieving the mechanical tasks of diabetes, improving outcomes and quality of life. But it's a long journey to get technology from a development, testing, proving its value, and embedding it in the NHS. Simplicity and automation are keys to those wider adoptions. And ultimately, this technology, I think, is helping improve health and minimize the burden of diabetes. Thank you.